It's my great honor and privilege to talk to you all today about intracranial infections, and also I'm very excited to show off our new logo. We get a new hospital in May at the San Francisco General Hospital, which is where I work, the Facebook Hospital. So very excited to try out these new slides. Let me find, there we go. So intracranial infections is a huge topic, and we're going to try and break it down. And how do we categorize all these? Well, we're going to go with an imaging-based approach. And I like this approach because it takes a lot of complex infectious patterns and breaks it down into digestible 5 digestible patterns that we can outline here. So there's the extraaxial pattern of infection, ring-enhancing lesions, temporal lobe predominant infection, infections primarily involving the basal ganglia, and those that are more white matter predominant. So while this is helpful and it's convenient to help hone down our differentials, understand that there's considerable overlap. And of course, a single infection such as TB or syphilis can have protein manifestations. But this will just highlight the most common presentations of the most common infections. So also remember that you can't practice radiology in a vacuum, so we must consider relevant clinical history. Immune status is probably the most important of those to consider. Patient age, we're going to focus mainly on adult infections in today's talk, as well as the acuity of the symptoms and geographic regions or recent visits to endemic areas. So let's start. We're going to do this in a very case-based way as we work through our patterns. We'll start with extraaxial. This was a 44-year-old man who was status post a right temporal bone cholesteatoma resection. And on first pass, you pick up some fluid from the postoperative change in the right mastoid air cells. And then you notice this lentiform, kind of biconvex collection in the middle cranial fossa. It's T2 hyperintense and has this thick rim of enhancement. And given the recent surgery and the symptoms of fever that the patient was reporting and headache, we're concerned about infection here, and we got diffusion imaging to confirm that small T2 hyperintense collection is indeed reduced on diffusion. So that helps us suggest this is pyogenic, kind of dense material that's hindering the diffusion of water molecules, giving us that bright signal. But don't stop there. When you have an epidural collection, you need to look for secondary complications. And in this case, we see in that right sigmoid sinus, there's absence of the normal flow void, and there's absence of contrast enhancement on our post-con image we can see with this arrow. So all consistent with epidural abscess following surgery with a secondary venous sinus thrombosis. Epidural abscesses are common extraaxial infections in the setting of surgery, as well as sinus disease, as we'll see. It presents as a lentiform extraaxial collection. Reduced diffusion can often be very helpful in distinguishing this from more simple collections. It's often frontal, and that's because the most common etiology is from a paranasal sinus infection or from infection of the mastoids. In our checklist, don't forget to look at the dural venous sinuses, as in this case where we saw a infectious thrombosis. Also interrogate the brain carefully with MRI. Make sure you're not missing a secondary meningoencephalitis or a frank abscess in the brain. And contact neurosurgery right away. Pick up the phone. This is a surgical emergency. Here's a case with the CT showing a small lentiform extraaxial collection over the frontal pole, and the patient had bad paranasal sinus disease. You can see some opacification of the frontal sinuses here. Here's a case, more of a mimic than a true infection. This is a 54-year-old female who presented with altered mental status. I didn't provide this history, but it was also noted that she had had respiratory failure and had been on high oxygen therapy. And this is actually high flow artifact. This looks like a T2 weighted image at first pass. However, you look at the ventricles and see that they're suppressed. So this was actually a flare image. And the CSF in the subarachnoid space remains bright. So it's failure of suppression of the flare of the CSF signal with flare. This is related to the paramagnetic effects of oxygen. So when it's very diffuse like this and smooth, the patient doesn't have any history of cancer or symptoms of infection, it's something to consider as a mimic of a leptomeningitis. And here's our little more expanded differential diagnosis of abnormal signal in the subarachnoid space. I'll let you read through that. This one's not so much of a mimic. This is a patient who was altered, immunosuppressed, and has this very high-density collection throughout the basal cisterns. Looks like the ventricles are a little dilated. Now, this actually presented as a stroke case and was initially interpreted as what we see 99% of the time when we have high density in the basal cisterns as a subarachnoid hemorrhage. However, the patient got contrast as part of the stroke workup, and we can see that that high density is even higher density after contrast. This is true enhancement. Subarachnoid blood will not enhance. This led to a diagnosis of a basilar meningitis based on the imaging, and it turned out to be coccidiomycosis. There's still a differential. Hemorrhage is less likely in this case with the enhancement pattern. However, we should still consider cancer and sarcoid. Along the infectious spectrum, we think about the granulomatous types of infections, fungal, TB, and also granulomatous inflammatory diseases like sarcoid. CSF sampling, clinical history, and chest x-ray can often help you nail down the diagnosis. Sorry, I said TB. This was coccidiomycosis, I think. Another case of coccidiomycosis, and here you can see how important it is to always get spinal imaging in these patients. You can see the continuity of the subarachnoid space from the posterior fossa down to the spinal canal. And so it's very common to have extension of this granulomatous infection throughout the spinal axis. So always get spine imaging in these patients. Again, we can see this avidly enhancing basal meningitis, a little bit of dilated temporal horns as well. So coccidiomycosis. This is a fungal infection. It's endemic to southwestern U.S., Central and South America, and it causes the valley fever. Most patients get a mild pneumonia, recover. A small subset of patients, including the immunocompromised, but you don't have to be immunocompromised to get this disseminated form of the infection, where you can get extensive CNS coccidiomycosis. I just show these images. You can see here this is an angiogram, and we can see all this enhancing exudate in the basal cisterns, just bathing these arteries, which are supplying critical nutrition, blood to the brain. So as a consequence of a basilar meningitis, think about strokes, as these infections like to gum up the small lenticulostriate branches. This is a non-con CT, and all we can see is some maybe dilated ventricles, as well as some low density here in the basal ganglia and anterior thalamus. This was a stroke confirmed on MRI, secondary to a basilar meningitis. Changing gears a little bit, we're still in the extraaxial space. This was a 24-year-old with aplastic anemia, severely neutropenic. And we see on the coronal MRI, kind of subtle if you haven't seen this finding before, but once you notice it, it really sticks out. This extensive flare hyperintense signal right along the ependema of the ventricular system. We can see it throughout. It was a very diffuse finding. On the post-contrast imaging, again, very subtle. I don't know if it's projecting well, but you can make out a little bit of ependymal enhancement and maybe a little leptomeningeal enhancement as well over the convexities. This patient in this immunocompromised state with this pattern of flare and enhancement is very suggestive of a CMV ventriculitis. And here are some of the imaging features which we just discussed, often associated with global atrophy of the brain as well. Let's move on to our second pattern, the ring enhancing pattern. This is every radiologist's favorite mnemonic. What a great one, magic doctor. In the setting of infection, we're going to be thinking about abscess. And we're going to look at how T2 imaging, diffusion, and a little bit on spectroscopy can help us come down on this diagnosis. And we'll look at the different enhancement patterns depending on the etiology of the abscess, and whether they're single or multiple can also help you narrow your differential. Abscesses can be caused by a number of infectious agents, as I've listed here. This is the characteristic brain abscess caused by a bacterial infection, a pyogenic abscess. And what really sticks out on the T2 image is this large, kind of predominantly hyperintense, but a little heterogeneous central collection with a rim that's very T2 hypointense and quite a bit of surrounding edema. post-contrast, we see that pseudocapsule, that T2 hypointense rim is avidly enhancing, and these central contents demonstrate uniform reduced diffusion. Highly suggestive of a brain abscess. You correlate with the clinical history, and you come down hard on that diagnosis. The one big differential to consider here is an intraparenchymal hemorrhage, which can have very similar diffusion characteristics, but often you can tease these out with clinical history. A quick word on spectroscopy and how this can help you nail down the diagnosis. Often it's used just for kind of further confirmation of your already strong suspicion. Spectroscopy is a technique that allows us to interrogate specific metabolites in the brain tissue. The big three here are the choline, creatinine, and AA that we can all remember approximately where they line up on the spectrum. And you want to see them go up like this nice hunter's angle, choline, creatinine, and AA, following kind of the trends we like to see in our stock market. Now, here's a case where we've used a single voxel to sample the center of an abscess. And, we're looking for our hunter's angle, and there's not much left of an NAA peak. We don't really see much creatinine or choline either. So that's because we're really just sampling liquefied pus. But what we do see in that abscess is this lactate doublet, as well as a peak around 0.9 for our cytosolic amino acids. So again, if this was a dilemma, you're debating between hemorrhage or infection, this spectroscopy may give you some further confidence, but usually not the primary means to make the diagnosis. When you do an intermediate echo, sometimes you can confirm this is the lactate peak by watching its inversion at 144 milliseconds. 76-year-old woman with seizures. We see this all the time, particularly at our county hospital. Parenchymal calcifications all over the place. Looks like old infection, old neurocystosarcosis. But don't stop there. She's symptomatic. She's had a seizure. Neurocystosarcosis is incredibly common in endemic populations. And she actually has, as we can see here, some ill-defined loss of gray-white and cerebral edema here in the inferior parietal lobe. On the post-contrast imaging, it's much easier to see this ring-enhancing mass. Diffusion is interesting in that the fluid component of this cyst doesn't have reduce or hinder diffusion. It's more simple fluid. The scolex itself, however, which is where the larva for the neurocystosarcosis is developing, will show a little punctate iso or hyperintense signal on the diffusion imaging. So this was an active case of neurocystosarcosis. It's caused by the parasite Tinea solium, and the features that we've talked about are mentioned here as cysts with the dot related to the scolex. It's transmitted by fecal-oral transmission, and humans are the intermediate hosts of this by ingesting eggs, which then go on to circulate into the brain and muscles. When they're in the CNS, the larvae kind of develop in the brain tissues. They love to form all over the CNS, but particularly in the brain. In a small subset of patients, 3 to 5%, you can get a racemose variant, which has a predilection for the ventricular and cisternal portions of the brain. These do not have a scolex, and they have these kind of grape-like formations in the CSF. It requires a longer treatment and harder to treat. A quick reminder, this is a nice image from this excellent review on parasitic infections of the stages. I won't go through this in detail, but remember you start with a vesicular stage without much inflammation. This larva is still alive, and you're just basically following CSF in the cystic component. And the colloidal stage is the stage that we see in our case we presented, where that larva is starting to break down and die. We're getting a lot of reactive inflammation around the cyst. This is the most dangerous time for the patient, where there's significant brain edema, herniation, and side effects from the mass effect. The rim enhances, and then over time, as the immune response wears down, it becomes more nodular granular, less edema, and eventually it kind of involutes into this calcified chronic stage. Here's a 30-year-old man just to show who presented with seizure as well from an endemic region. And here we can see these kind of loculated CSF collections. And the perisylvian region is a very common location, as well as the CP angles for this racemose variant of neurocystosarcosis. No real significant enhancement. Continuing with our ring-enhancing differential, this is a 45-year-old with altered mental status. See from this first image, there's a clear basilar meningitis. We can see this extensive enhancement along the PI and the ventricle. So that kind of belongs in our last pattern, the extraaxial. But associated with that, we also see these ring-enhancing masses. And when you see a basilar meningitis plus enhancing parenchymal lesions, you should start thinking about TB, tuberculosis, worldwide actually increasing in incidence. On the T2 images, it's kind of interesting in that we see the areas of kind of central non-enhancement are actually fairly dark on the T2 image. And that's very characteristic of the parenchymal lesions of TB, the most common parenchymal lesions known as tuberculomas. And that dark T2 signal relates to the caseating material from the granulomas that are forming in response, those giant epithelioid cells. Frank TB abscess is actually quite rare, where you have a true cystic abscess that very much mimics a pyogenic abscess. More commonly, you see these tuberculomas. And when you see it in the setting of a basilar meningitis, always think about TB. Also, in your imaging checklist, think about complications. Infarcts, as we discussed with basilar meningitis, secondary vasculitis. Take a look at their chest x-ray. Our middle pattern here is the temporal lobe. This will be a quick one. We're just going to focus on herpes. And herpes is just a diagnosis you don't want to miss. So whenever you see some abnormal signal in the temporal lobe, herpes should cross your mind. Even if it's very far away from the actual diagnosis, if you see something abnormal in the temporal lobe, think herpes because it's treatable and you can save someone's lives. And often you, the radiologist, will be the only person to consider it. So here's a case of the non-con CT showing this ill-defined kind of low density in the mesial temporal lobe. It looks a little swollen. The MRI, it's much more clear that the temporal lobe as well as the inferior frontal lobes have extensive edema. And there's, on diffusion imaging, associated diffusion abnormality, reduced diffusion. So this was a case of HSV encephalitis, demonstrating a lot of the characteristic imaging features. Temporal and inferior frontal lobes. Bilateral is often how it presents, but it's usually asymmetric. Can have reduced diffusion. You can have enhancement. It's a very rapidly progressive disease, and it can often occur in the immunocompetent patient. There's differentials to consider. Again, you always think about HSV and mention that when appropriate. In this case, we see some ill-defined low density in the temporal lobe. As we move up, though, we see this is really fitting more of a vascular territory. Then we went back and looked, and oh, there's a really dense MCA sign. So this is actually an MCA stroke, one of the mimics. Here's a case where we have this just extensive expansile, almost mass-like edema, really is mass-like, involving the temporal lobe, inferior frontal lobes. So distribution would be certainly concerning here for herpes encephalitis. But it turns out this patient had a very insidious onset, and this had been progressing for months, and the imaging as well as the clinical was more suggestive of a low-grade gliomatosis. Here's a coronal flare image where we can see this extensive asymmetry, this bright T2 signal abnormality in the hippocampus. This was a patient in status, and this was thought to be post-ictal in nature. You certainly can have seizure activity with herpes, so it's something to consider and throw out there for them to work up, but this turned out to resolve with resolution of their seizure activity and was related to post-ictal. Here's a case again where we have this abnormal edema in the mesial temporal lobe on the right side. This was very subacute progression for this patient. They had an ovarian mass. This turned out to be a limbic encephalitis, which is commonly associated with ovarian teratomas, an autoimmune disease. Fourth pattern here is our basal ganglia predominant. We could do a whole day talking about basal ganglia abnormalities, but we're just going to focus on HIV-associated infections that commonly involve the basal ganglia, particularly crypto and toxo, as well as a tumor mimic lymphoma. So here's a case of cryptococcus where you have ill-defined kind of patchy flare hyperintensity in the basal ganglia. Notice on the diffusion that it's very watery. It's very bright or dark facilitated diffusion, not reduced in diffusion, and there's no significant enhancement. And these are the classic gelatinous pseudocysts that form as the basilar meningitis spreads up along those lenticular striate vessels and forms these cystic fluid collections, very watery fluid collections along the perivascular spaces. Characteristic feature of cryptococcal meningoencephalitis. This is an opportunistic infection, usually AIDS patients severely immunocompromised with CD4 counts under 100. You'll see a basilar meningitis, and the gelatinous pseudocysts are often present, as we discussed. You don't always have to have those. This was another case, not a basilar meningitis, actually had a leptomeningitis up near the vertex with these very T2 hypointense signal in the leptomeninges and hyperenhancement. This turned out to be Cryptococcus as well. So it can have some atypical presentations. Here's another disease of the immunocompromised, toxoplasmosis. We can see these big mass-like enhancing lesions in the basal ganglia. They also like to involve juxtacortical regions of the brain, but basal ganglia is a classic location. Diffusion, again, not real convincing for pyogenic abscess, and that we don't see the characteristic frank reduced diffusion. The enhancement pattern's pretty specific when you see this, not as sensitive, but when you see this eccentric nodule within a ring of enhancement, the so-called eccentric target sign, that can help you come down on a differential of toxoplasmosis. Again, this is a parasite that infects the immunocompromised. We talked about the eccentric target sign. And our big differential with toxo is going to be CNS lymphoma. So it's not uncommon to have to try and distinguish these two because they both occur in the immunocompromised patient. Toxo tends to be multiple in numbers, whereas CNS lymphoma can be multiple, but more commonly solitary compared to toxo. Lymphoma is the second most common brain lesion in AIDS patients after toxo. On CT, it's hyperdense, dark on T2, and you'll have reduced ADC values. There are a couple of other imaging features we can look at to help us kind of cone down that differential, particularly thallium and MR perfusion we'll take a quick look at. So this is an MR perfusion scan, and we can see we have this, I don't have the anatomic imaging, but from the perfusion data you can see this lesion with susceptibility artifact kind of around this irregular rim. And when we look at the perfusion map for the cerebral blood flow of this lesion, we can see there's elevated cerebral blood volume in that area. And this was actually enhancing on our T1 post-contrast images. And when you look at the profile, you can see that area sampling, that bright area, has a big area under the curve. So lots of perfusion to this lesion, consistent with a lymphoma more so than toxoplasmosis. In toxo, the perfusion imaging usually is pretty dark, signal void, hypoperfusion related to kind of necrotic mass of infection. Thallium SPECT has also been proposed. We don't use this, but it has been documented as a fairly reliable way to distinguish these two. With lymphoma, you're going to see increased uptake on SPECT of thallium, whereas toxo is going to be basically no significant uptake. So how do we realistically deal with this when we can't come down hard on a differential? Well, often they will empirically treat the patient for toxoplasmosis for a couple of weeks. And if there's clinical and radiologic improvement, we'll presume that it was effective treatment of toxoplasmosis. In the absence of any improvement or progression of disease, then they'll often move on to biopsy and under suspicion that this is CNS lymphoma. CJD is one of these atypical kind of infectious agents, not really related to an infectious organism per se, but to misfolded proteins. It results in a rapidly progressive dementia. The most common type of this is the sporadic form, and with sporadic CJD, you get this extensive edema, flare hyperintensity, and reduced diffusion involving cortical ribbons, as well as the basal ganglia, particularly the caudate and the putamen. It doesn't really fit a vascular territory, so that should be a clue that this may be CJD, and then you correlate with the history and the EEG findings. The sporadic subtype, as I said, is the most common. The variant subtype has also been described in about 10% of cases, and one somewhat unique feature on imaging for this variant, which is associated with eating cattle that have this abnormal protein, is the so-called hockey stick sign, where the pulvinar of the thalamus has this abnormal flare hyperintensity that extends along the medial thalamus. Kind of looks like a hockey stick, I guess. Moving on. Our final pattern are the white matter infections. And again, white matter lesions, a very broad differential. For infection, we're going to focus once again on our AIDS patients, our immunocompromised, and the most common manifestations of PML and HIV in the AIDS patient. This was a 52-year-old with HIV, altered mental status. We see these kind of very eccentric subcortical flare hyperintense lesions in the frontal and the parietal lobes, and no real significant enhancement or mass effect with this. The diffusion, maybe a little leading edge reduced diffusion that was confirmed on the ADC maps. And this was all consistent with progressive multifocal leukoencephalopathy, which is caused by the JC virus. The characteristic imaging features for PML, again, are no mass effect, no enhancement, asymmetric, extension up to the subcortical U fibers, so all the way up to the cortical surface, and peripheral rim of hindered diffusion. HIV encephalopathy, on the other hand, tends to be associated with global cerebral atrophy. It is frontal predominant, a little bit more symmetric bilateral, and relatively spare is that rim of subcortical U fibers that we see here. So both lesions don't have significant mass effect nor enhancement. And here are some of the features we can use to try and distinguish these. I like just to keep it simple and remember the P's of PML, the 3 P's. Patchy, that infers that it's asymmetric, peripheral, going all the way up to the U fibers, and posterior, although it can be frontal, more commonly tends to be parietal. So in conclusion, we use these patterns of abnormality on brain MRI to help us cone down our differential, understanding that there is significant overlap. And we've been through some of the more common entities within each of these patterns. You must approach this with a good knowledge of the clinical history, particularly the immune status of the patient. And hopefully we've pointed out some helpful specific imaging features that can help you cone down your differential further, particularly diffusion, spectroscopy, and perfusion imaging.